At MSC Sleep, we pride ourselves on being a best-in-class CPAP provider. MSC has a standardized CPAP setup curriculum that ensures all patients receive consistent, quality content along with standardized visual aids and reference material. Whether set up in person or virtual, each patient receives the same content, information, and education. Our standardized curriculum goes well beyond simple device and mask training. We provide disease education, acclimation tips, usage requirements, and how to contact a sleep coach. Having a proven standardized model drives compliance and ensures consistency. We can feel confident that a patient in Kansas City gets the same quality setup as a patient in Cleveland. At MSC, we empower every patient to succeed with PAP therapy. It is our goal to improve their sleep quality and their overall health and quality of life. To learn more, please visit our website at medicalserviceco.com/sleep therapy.
Good afternoon and welcome to the second lecture in today's sleep track presented by Dr. Donna Arand. Dr. Arand will be speaking on behavioral treatments for insomnia. She has a PhD in psychology and is an associate research professor at the Wright State University School of Medicine in Dayton, Ohio. She is the past president of the Society of Behavioral Sleep Medicine and has served on the board of the American Academy of Sleep Medicine and the board of registered polysomnographic technologists. Dr. Arand has over 100 publications in the areas of insomnia, arousal, sleep deprivation, and daytime performance. We're very appreciative of Dr. Arand's participation as a speaker during this year's forum. If you have any questions or comments for Dr. Arand, be sure to enter them under the Engage tab so they can be addressed immediately following her lecture. Don't forget to complete and submit your post-lecture evaluations to receive credit for this session.
Hello, I'm Donna Arand, and my presentation is on the behavioral treatments for insomnia. Now, insomnia is an extremely common problem that has significant impact on health and daytime functioning for individuals of all ages. It's estimated that 10% of adults have chronic insomnia, along with another 15 to 20% that report short-term insomnia. Insomnia is even more pervasive in adolescents, where 40 to 60% report insomnia symptoms. Insomnia contributes to 40% of all auto collisions and increases the risk of auto accidents by up to 45%. Additionally, the impact on health and healthcare costs is enormous, generating over 5 million doctor visits per year, and if left untreated, it results in additional healthcare costs of more than $63,000 per person per year. This high prevalence and cost of insomnia makes diagnosis and treatment so important. So what is the treatment? According to clinical practice guidelines of the American Academy of Sleep Medicine, the American College of Physicians, and the European Sleep Research Society, cognitive behavior therapy, or CBT-I, is the recommended first line of treatment for insomnia. Behavioral techniques have also been shown to be as effective as hypnotics in the short term and superior for long-term benefits without side effects that can occur with hypnotics, such as daytime sleepiness, or in the case of non-benzodiazepines, parasomnia activities such as sleepwalking that can result in serious injury or even death. So what is CBT-I? CBT-I typically consists of 6 to 8 sessions. The first CBT-I session usually reviews the problem, sets goals for treatment, describes the program, and provides education about sleep and sleep hygiene. Numerous questionnaires are completed, and the person begins keeping a sleep diary that is reviewed as the sessions progress. Subsequent sessions introduce various behavioral interventions as appropriate for the individual, but generally they include a discussion of sleep hygiene. Stimulus control, which requires the person to get out of bed after 20 minutes of not sleeping and go into another room to do non-stimulating activities until they're sleepy, at which point they can return to bed. The process is repeated throughout the night. Using the bed for other activities except sleep or intimacy is not allowed. And this is a form of conditioning to reassociate the bed with sleeping rather than being awake. Sleep restriction is another intervention that limits the time in bed to the average time a person is asleep. Time in bed is evaluated and increased by 15 to 30 minutes per week if the sleep efficiency is 85% or more. Relaxation techniques are also used, and these can include things such as deep breathing, yoga, meditation, or mindfulness. These are taught in the sessions and practiced during the day, and then they can be used at night in bed if the person is awake. Cognitive therapy is used to examine dysfunctional beliefs about sleep and to change a person's thinking. For example, if someone thinks that insomnia is the reason they're about to lose their job or their marriage is in trouble, these associations are discussed and examined in terms of responsibility and other causes. Because dysfunctional beliefs increase the pressure on the need to sleep, they are counterproductive and they do need to be addressed. The final session usually reviews the interventions used and discusses relapse prevention. So when sleep problems reappear in the future, the individual knows what to do and the interventions to use. It's important to note that all the behavioral interventions can be used independently, but are typically combined in CBT-I. While CBT-I is the most common treatment, behavioral interventions come in many forms to treat individuals of all age groups. So let's look at behavioral interventions in children. Studies on young children show that behavioral interventions are very effective. This study examined the use of parental education and a breathing exercise intervention on increasing sleep time in hospitalized children. This was a random controlled trial on 48 hospitalized children ages 4 to 10 who were divided into two groups. The Relax to Sleep treatment group involved an education session for the parent and a booklet on training the child in diaphragmatic breathing. This involves slowly inhaling so that the abdomen is raised as much as possible, holding the breath for 3 seconds and slowly exhaling. The second group was a control group that received usual care but no information on sleep or relaxation. Actigraphy was used for 3 days and nights on children, and the parents completed sleep diaries for the children. The results showed that the Relax to Sleep group averaged 50 minutes more nighttime sleep and 40 minutes less wake after sleep onset at follow-up compared to controls. Additionally, parents found that the breathing exercises were easy to use, and they indicated they would use them in the future if the need arose. It was concluded that diaphragmatic breathing is a useful sleep intervention to use in hospitalized children. Another study evaluated the short and long-term effects of CBT-I in children. This study included 112 children, 5 to 10 years of age, with chronic insomnia. They were divided into two groups in a 4-to-1 ratio. A CBT-I group initially had 86 children, and the control group had 26 children, but both had high dropout rates of 67% and 57% respectively. The intervention for the CBT-I group included 3 100-minute sessions for children and parents separately. Therapy puppets were used to strengthen the treatment interventions. Week 1 involved avoiding naps, delaying bedtime until sleepy, explaining sleep hygiene, and teaching deep breathing. Week 2 included stimulus control, imagery metaphors, and hypnotherapy, which was relaxation with conducive images. The third week included reviewing the interventions, consolidating and summarizing the content and the strategies used. The measures were obtained at baseline, post-treatment, 3, 6, and 12-month follow-up. They included actigraphy for 1 week, sleep diary for 2 weeks, although only the second week of data was used, and a children's sleep habit questionnaire. Results showed that post-treatment, 59% of the CBT-I children no longer met criteria for insomnia. However, 41% still met criteria for insomnia in the treatment group, but that was compared to 100% of the control group still having insomnia. In addition, sleep onset latency, sleep efficiency, and number of awakenings significantly improved in the CBT-I group, but not in the control group. Total sleep time did not improve in either group, and both groups showed that parent-rated sleep on the children's sleep habit questionnaire significantly improved at post-treatment. Looking at the long-term effectiveness at 3, 6, and 12 months, sleep efficiency significantly improved in the CBT-I group from baseline to post-treatment and was maintained over the 12-month period. Similarly, there was significant decrease in sleep onset latency that continued to improve over the 12 months, as did the number of awakenings, which dramatically decreased from 5 to 1 at 12 months. The children's sleep habits questionnaire improved for both groups over the 12 months. Looking at the percent of children who still met criteria for insomnia after CBT-I, the graph shows a significant drop to 41% post-treatment, with a continued decrease over the 12 months, with only 13% still having insomnia at the 12-month period. This pattern was consistent even when adjusted for the high dropout rate. In summary, CBT-I resulted in greater improvement than controls on objective and subjective sleep measures, and these improvements persisted over 12 months. So it was concluded that CBT-I shows both short and long-term effectiveness in school-aged children. Now we're looking at the behavioral treatment of insomnia in adults. CBT-I has been shown to be effective in hundreds of studies, but the more recent studies have begun focusing on effectiveness in more challenging groups, such as those with comorbidities. Probably the most common comorbidity is depression. And this study examined whether CBT-I is effective in older adults with comorbid insomnia and depression, and also compared CBT-I to CBT-I plus mood strategies for its effectiveness. The study involves 72 individuals with a mean age of 75, and they had both insomnia and depression. This was a random controlled trial with 3 groups, a CBT-I group, a CBT-I plus mood strategies group, and the mood strategies included things such as activity scheduling, cognitive reframing, thought diaries, and positive data logs. A 3rd group was a psychoeducation control group. The 2 treatment groups had 8 weeks with a 60 to 90 minute group session each week, and the measures included insomnia severity index and geriatric depression inventory, and these were obtained pre and post treatment as well as at 20-week follow-up. Results showed that CBT-I and CBT-I plus the mood strategies both produced significantly greater reduction in insomnia and depression severity compared to the control group. Large effect sizes and remission rates were maintained at the 20-week follow-up. And you can see the control group in green at the top of both graphs, showing almost no change in insomnia and depression severity. It was concluded that both CBT-I and CBT-I with mood strategies are effective in reducing insomnia and depression in older adults. An interesting study looked at CBT-I and CPAP use to determine if initial treatment with CBT-I improves CPAP use in individuals with obstructive sleep apnea and insomnia. The participants were 145 people aged 18 to 75 with insomnia and moderate to severe OSA with an AHI greater than or equal to 15. They were divided into 2 groups, a CBT-I group plus CPAP or a treatment as usual group plus CPAP. The procedure for the CBT-I group included 4 weekly 45-minute CBT-I sessions before CPAP was introduced. The sessions included sleep restriction, sleep hygiene, and sleep information, cognitive therapy, and review and relapse prevention. Measures were obtained at baseline, 6 weeks, 3 months, and 6 months. The primary outcomes were CPAP adherence and objective sleep efficiency at 6 months. Other measures included PSG and diary measured sleep parameters and the insomnia severity index. Diary measured sleep efficiency was significantly higher in the CBT-I group at 6 weeks compared to baseline. The same pattern was also seen in sleep latency and wake after sleep onset, although it is not on these graphs. The insomnia severity index scores also significantly improved at 6 weeks compared to baseline in the CBT-I group, and this improvement was maintained at 6 months. There was no difference on objective polysomnography measures at the 6-month period. In terms of CPAP use, the CBT-I group had a higher initial acceptance of CPAP than the control group. In addition, CPAP use over the 6 months showed that the CBT-I group was using CPAP about 1 hour more at the 6-month period, although both groups showed a significant decrease in CPAP use over the 6-month period. There was no difference in daytime impairment or objective sleep between groups at 6 months. it was concluded that CBT-I prior to initiating CPAP improves CPAP use and insomnia compared to a CPAP-only group. I want to add here also that a subsequent study was done this year and also looked at CBT-I and PAP use, but it included mild OSA patients with an AHI less than 15. And that study found improvement in insomnia, but no difference in the CPAP use compared to the PAP-only group. So this indicates that the impact seen in the study just presented may only be found in moderate to severe OSA patients. Now, a timely and important area in the treatment of insomnia is the development of digital or online delivery of CBT-I. A number of digital programs have been developed, including Sleepio, Shut-Eye, Somrest, as well as many others. The digital delivery of CBT-I can address the shortage of CBT providers and increase access to diverse populations, as well as address the challenges of delivering treatment during a pandemic. Recent studies have looked at the efficacy of online treatments. This study looked at the short-term efficacy of unguided internet-based CBT-I using a large sample and an active control group. It was a random controlled trial with 181 people, mean age 45, with insomnia, who were divided into two groups. A group that used the Shut-Eye program, consisting of 6 cores, accessed 1 week apart, and another group receiving web-based education. Both groups completed a 2-week diary at baseline, followed by 9 weeks of intervention, and then another 2-week sleep diary. Measures of insomnia, severity, and the Bergen Insomnia Scale were obtained at baseline and after treatment for both groups, and at 6 months for the Shut-Eye group only. Results for the Shut-Eye group showed a significant decrease in both insomnia scores at post-assessment compared to baseline. These were also significantly lower than controls, and these improvements were maintained at 6 months. However, the results also showed a very high dropout rate. Initially, 19% of the Shut-Eye group and 24% of the control group dropped out at post-treatment. This increased to 58% of the Shut-Eye group dropping out at 6 months. However, it was concluded that unguided internet-based CBT-I produced significant short-term improvements in insomnia patients, and these improvements were maintained at 6 months. Interestingly, a subsequent study followed up on these same patients and found that all improvements were maintained at 18 months as well. While the effects of CBT on nighttime symptoms of insomnia appear very robust, daytime symptoms are also a core part of insomnia. This study looked at the effects of digital CBT-I on daytime measures of health, well-being, and quality of life in a random controlled trial of 1,711 volunteers with insomnia who were divided into 2 groups. The first group was a digital CBT-I group using the Sleepio program that involved 6 sessions, 20 minutes each, that were available for 12 weeks. The second group was a control group that got sleep hygiene education involving 1 session with a web page to view and a downloadable booklet. Online assessments were made at baseline, 4, 8, and 24 weeks follow-up. The measures included Global Health Scale, Glasgow Sleep Impact Index, Psychological Well-Being Scale, Quality of Life, and an Insomnia Indicator. Secondary outcomes included mood, fatigue, sleepiness, cognitive failure, and work productivity. The results showed a high dropout rate for the CBT group, with 81% logging in for at least one session, but only 48% completing 6 sessions, compared to 89% of the control group logging in for the one session. The digital CBT group had significant improvements in global health, mental well-being, and quality of life at all test points compared to the control group. In addition, psychological measures of depression, anxiety, sleepiness, cognitive failures all showed significant improvement throughout the 24 weeks for the CBT-I group. Insomnia was also significantly improved in the CBT-I group, and the decrease in insomnia accounted for 45 to 84% of improvement in all the other measures. It was therefore concluded that digital CBT is effective in improving functional health, psychological well-being, and quality of life in people with insomnia. Furthermore, a reduction in the insomnia symptoms mediated the improvements in other parameters. Other interventions have also been tested and compared to CBT-I, because CBT-I is the de facto gold standard for the treatment of insomnia. Now, this study compared the efficacy of 6 weeks of home-based aerobic exercise to CBT-I in cancer patients with insomnia. 41 patients with cancer and insomnia were randomized into an exercise control group or a CBT-I group. Measures were obtained at pre- and post-treatment, as well as 3 and 6 months follow-up, and they included the Insomnia Severity Index, the Pittsburgh Sleep Quality Index, sleep diaries, and actigraphy. Results showed that CBT-I and exercise significantly improved the Insomnia Severity Index, wake after sleep onset latency, and the Sleep Quality Index at post-treatment, and these improvements were maintained at 3 and 6 months periods of time. In addition, total sleep time and sleep efficiency were significantly increased by exercise and CBT-I at post-treatment, and they continued to improve at the 6-month point. While most sleep diary parameters significantly improved in CBT-I and exercise groups, the objective actigraphy data did not show a difference. Additionally, while all participants showed improvements in insomnia, only 30% of the CBT-I and 35% of the exercise groups were in remission at the end of the study. So the majority of participants in both groups still had insomnia at follow-up. It was concluded that exercise and CBT-I significantly improved sleep in cancer-related insomnia patients. Now, this study compared the efficacy of acupuncture to CBT-I in cancer survivors. This was a random controlled trial of 160 cancer survivors who were divided into two groups, a CBT-I group and an acupuncture group. Participants had either 8 weeks of acupuncture or CBT-I. Testing occurred at baseline, 8, 12, 16, and 20 weeks, and included Insomnia Severity Index, Pittsburgh Sleep Quality Index, a sleep diary, a pain inventory, fatigue, anxiety, depression scales, and a patient-reported outcomes measurement scale. The results showed that CBT-I and acupuncture significantly reduced the Insomnia Severity Index and Sleep Quality Index, and these improvements were maintained at 20 weeks. It was also noted that CBT-I was more effective than acupuncture for improving sleep quality. Additionally, CBT-I was found to be more effective than acupuncture for decreasing sleep onset latency and wake after sleep onset. In contrast, acupuncture was more effective for increasing total sleep time. Finally, both groups had similar improvement in fatigue, anxiety, depression, and quality of life. It was concluded that both acupuncture and CBT-I produced clinically meaningful reductions in insomnia that were maintained at 20 weeks. However, CBT-I was considered more effective overall. Now, this study compared numerous interventions for insomnia in women with vasomotor symptoms, otherwise known as hot flashes, by looking at data from 4 random controlled trials that included a total of 546 peri- and postmenopausal females. The interventions included yoga, aerobic exercise, omega-3 fatty acids, CBT-I, estrogen, and 2 antidepressants. The measures included the Insomnia Severity Index and the Pittsburgh Sleep Quality Index, and they were measured at baseline, 4, 8, and 12 weeks of treatment. The results showed that the Insomnia Severity Index decreased in all groups except the omega-3 group, with the greatest decreases occurring in the CBT-I group. Similarly, on the right, the Sleep Quality Index showed similar pattern, with CBT-I showing the greatest change and the omega-3 group showing the least change. It was concluded that CBT-I should be the first line of treatment in healthy women with insomnia and vasomotor symptoms. Now, there are also some unique interventions for insomnia that have recently been studied. If you live on the International Space Station where there is no gravity, going to sleep in a mummy bag and velcroing yourself to the side of the wall or to the ceiling wearing a large black blindfold is the preferred way of going to sleep and staying asleep. However, if you live on Earth with the rest of us, there are other more practical, unique measures. This study looked at whether a warm shower or bath before bedtime improves sleep. This idea stems from the fact that body temperature begins dropping prior to sleep onset. So it was hypothesized that by artificially raising the temperature prior to sleep, the subsequent drop could help trigger sleep onset. A literature search of 6 large databases found 13 studies with comparable quantitative data on which a meta-analysis was done. The measures included sleep onset latency, total sleep time, sleep efficiency, and sleep quality. The results showed that passive body heating in 104 to 109 degree temperature water improved sleep efficiency and sleep quality. When the bath was scheduled 1 to 2 hours before bedtime, for as little as 10 minutes, it significantly shortened sleep latency by 10 minutes. The optimal timing of the bath was determined to be 90 minutes before bedtime. So it was concluded that warm baths 1 to 2 hours before bedtime will increase the chance of falling asleep faster and result in better quality of sleep. At the other end of the temperature spectrum, this study looked at cooling the body to improve sleep. In this study, a device that cools the forehead was tested to see if it improves sleep difficulties and hot flashes in postmenopausal women. The device is a headband containing a water-filled bladder that is connected by tubes to a unit that cools and cycles the water at a preset temperature. This study included 20 women with insomnia and 2 or more hot flashes daily. The procedure involved completion of sleep diaries and hot flash logs for 1 week at baseline, then for an additional 4 weeks while using the forehead cooling device at night. Results showed that compared to baseline, sleep onset latency and wake after sleep onset significantly decreased across the 4 weeks. In addition, the number of awakenings significantly decreased and sleep quality increased across the 4 weeks. Forehead cooling also significantly improved hot flash severity. So it was concluded that the use of a forehead cooling device improves sleep and reduces insomnia, hot flash severity, and other menopausal symptoms. A new popular item is weighted blankets, and one study evaluated the effect of a weighted chain blanket on insomnia and daytime symptoms in patients with psychiatric disorders. The participants were 120 individuals with various psychiatric diagnoses that were randomly divided into 2 groups. One group used a weighted chain blanket, the other group used a light plastic chain blanket. The groups used the assigned blankets for 4 weeks, and then all were switched to the weighted chain blanket till 12-month follow-up. Measures were obtained at baseline, 1 to 4 weeks of treatment, and at the 12-month follow-up. The measures included insomnia severity index, sleep diaries, the fatigue symptom inventory, and hospital anxiety and depression scales. The results showed a significant reduction in insomnia severity throughout the 4 weeks and through 12 months of follow-up for the weighted blanket, which is seen here in red. When control groups were switched to the weighted blanket after 4 weeks, they showed the same improvement in insomnia severity. Results also showed a significant reduction in fatigue, depression, and anxiety with the weighted blanket. It was concluded that weighted blankets are effective and safe for improving insomnia in patients with psychiatric disorders. Now, various relaxation techniques are used as part of behavioral therapy for insomnia. And this study evaluated the effects of Tai Chi training on sleep quality, depression, and social functioning in patients with major depression. The participants were 16 depressed Chinese Americans, mean age 54, and they had 1-hour Tai Chi training sessions twice per week for 10 weeks. The measures were obtained at baseline and following the Tai Chi sessions, and they included sleep quality, Beck and Hamilton depression scales, a short-form health survey, and a 24-hour ECG recording for determining objective sleep. The data showed significant improvement in sleep quality index, Beck depression scales, Hamilton depression scale, and these improvements occurred over the 10 weeks. There was also a dramatic decrease in the latency to stable sleep from 76 minutes to 20 minutes, along with improved health at 10 weeks compared to baseline. There were no correlations between objective sleep measures and depression. It was concluded that Tai Chi improves sleep quality and mood in depressed patients. And there is a final behavioral treatment that I will discuss, and that's the otter way. If you're an otter, you might find that floating on your back and holding hands in any temperature water is a very effective way of sleeping and allows you to just drift away. So, in summary, it's clear that CBT-I is a very effective treatment for insomnia. However, as many studies have indicated, not everybody is in remission following CBT-I. Some people have some remaining symptoms of insomnia, although all are significantly better off than they were prior to beginning treatment. So this means that we still have a long way to go in understanding all the aspects of insomnia and why not everyone gets to the same level of improvement. Insomnia is a chronic problem. It can change over time, and so any treatment will need to be considered ongoing, and individuals are going to have to be very careful about not allowing their sleep to get away from them and to start evolving into poor sleep habits and ultimately back into a period of chronic insomnia. In terms of the online CBT-I, this is clearly where the future is going, and it will be available to so many more people so that we can treat the 70 million people who have insomnia. However, the biggest problem with online CBT-I is the fact that a majority of people, over 50%, do not complete all the sessions in CBT-I. So there is a part of the population that probably needs face-to-face treatment, or we need to be working on other means and methods to include in CBT-I programs that keep people engaged and keep them motivated to continue the various sessions and to follow through. A number of studies are looking at guided CBT-I, where there's access to a therapist to help on a weekly basis to understand the interventions, answer questions, and provide support and guidance. And this is hopefully a way to increase the effectiveness and successfulness of behavioral therapy when it's provided online. If a person has a problem with chronic insomnia, they can talk to their physician, or they can look for a psychologist who specializes in the behavioral treatment of insomnia. There are licensed professionals that are listed on the Behavioral Sleep Medicine website. You can find individuals in your area who specialize in the delivery of CBT-I treatment. The other thing that I want to mention is the fact that behavioral treatments come in a variety of shapes, sizes, and forms. And there are many things that have been done throughout history that actually help improve sleep that are not pharmacologically related and that can be tested and used for the treatment of insomnia. So once we have data on a variety of behavioral interventions, the options for treatment will continue to increase, and hopefully we will end up with a very, very successful armamentarium of options for intervening to treat and to prevent insomnia. So with that, I thank you, and we will open it up to questions.
Thank you for joining us this afternoon. We have Dr. Donna Arand joining us for our live Q&A session. Dr. Arand, thank you so much for your lecture this afternoon and then joining us for the live session.
Oh, you're welcome. I'm glad to be here.
Thank you. During your lecture, we compiled a list of questions, and if you're ready, we'll begin.
Yes, I am.
Excellent. First one in says, what is the biggest obstacle to therapy adherence when using CBT-I with children?
I think the biggest obstacle in general is typically the parents. Parents on board to reinforce what you're doing with the child. Most children, the other thing is that if you get the instructions and the ideas down to the level that the child can understand, you will have a better outcome than if you try to treat them like, you know, a young adult. You know, using puppets, just using play items, getting them involved, asking them questions about what they like, and then trying to relate that to the sleep issues is key for the children. But apart from that, then you've got to get the parents involved so that the parents understand what's going on, because they're going to be there every night, and they have incredible influence over the behavior of the child and what's going to work. And you don't want them undoing or working against what you're trying to accomplish.
Excellent. Totally makes sense. Thank you. Next question. Do you have any recommendations for educational materials clinic staff could provide to parents and patients as well?
Yes, there's a number of free brochures, instruction sheets, information sheets on the websites of both the American Academy of Sleep Medicine as well as the Society of Behavioral Sleep Medicine. They have instruction sheets for multiple age groups, specifically for children as well. They have infographics, so you don't have to worry too much about reading if that's not your strong suit. And all of those can be downloaded for free and used for free. And I would certainly recommend going to either website for more information about insomnia and behavioral treatments.
Thank you very much. Next question. Should CBT-I basics be incorporated into CPAP training for early adoption?
Well, based on the study that I discussed, certainly at year's end, those who received CBT-I prior to getting CPAP were sleeping almost an hour more with CPAP. So that's an incredible difference. I think it would be useful, and it certainly, I don't think, can hurt. So I know there's been a recent study where they compared using CBT-I prior to CPAP initiation and then at the start of CPAP initiation to see if there was a difference in timing. And no, there wasn't a difference in timing, but yet that study also found that if the AHI was less than 15, there was no difference in outcomes for sleep or CPAP use. So I think we've identified a group that uses CPAP, that is the moderate to severe apnea patients, who would certainly benefit from CBT-I at some point, either prior to or at the start of receiving CPAP treatment. So I think the answer there is yes.
Excellent, thank you. Next question. How does age and development correlate with insomnia?
Well, any age group can have insomnia, but we certainly find more insomnia in middle-aged and older individuals, particularly females. Now, that's not clear whether it's just that females report insomnia more or complain about it more, but certainly in the middle-aged females and older adults in general, there is more incidence of insomnia. In younger children, particularly the adolescents, I think insomnia is confused with delayed sleep phase because, as we know, in your teenage years, your sleep shifts so that you really can't go to sleep at a normal time. Your body wants to stay up later and later. And some people mistake that for insomnia. And that is not insomnia. That's a different disorder. So other than having insomnia at various, and any age actually, it is more common in the middle-aged and older.
Thank you for that. The next question. Is CBT-I therapy offered through typical sleep clinics or with mental health specialists?
CBT-I for insomnia specifically, that's what the I stands for, that is offered through sleep disorder centers, specifically those that are accredited by the FAASM, because it's required that they have that option for patients, even if it's not in-house. There is a referral mechanism, and there's someone identified in that location that can provide CBT-I. Now, mental health services often do have people who can do behavioral therapy. Some do cognitive behavioral therapy. It's probably not common to find somebody who's specifically trained in cognitive behavioral therapy for insomnia per se, but there are a number of options for mental health organizations to either have someone who's knowledgeable or in training for CBT-I, or who can provide the specifics needed to guide another therapist who is there doing behavioral therapy for the individuals.
Thank you very much. As a reminder to our participant list, if you have a question, please type it in the chat box. I'll be able to view it and share it with Dr. Arand as we are going through the list of questions. Next question that's come up, is CBT-I therapy oh, I just read you that one. Excellent. Well, Dr. Arand, we really do appreciate you joining us today in this chat live Q&A session. I do see one more question popping up, so if you'd hang tight with me for just a minute, I appreciate it.
Oh yeah, I can do that. And I also want to add that in the last couple days, the updated paper for the clinical practice of behavioral treatment for insomnia has just been published online by the American Academy of Sleep Medicine. The previous one was almost 15 years ago. And this update specifically identifies cognitive behavioral therapy as the #1 strongly recommended treatment for insomnia in almost all adults. Less strong recommendations, but recommendations were also made for a briefer form of behavioral therapy, which is usually 4 sessions rather than 6 to 8 sessions, which is what is typical in a full behavioral therapy session. Also, there was strong evidence for stimulus control, sleep restriction, and cognitive therapy for to be used as independent treatments for insomnia in certain patient populations. Interestingly, and this has been created some confusion even among my own colleagues, is they did not recommend sleep hygiene as a single treatment for insomnia. And that's the key, a single treatment. Usually sleep hygiene is used in combination with other behavioral therapies. And so it's not surprising that sleep hygiene alone won't treat chronic insomnia. And from my perspective, I strongly believe the reason is that sleep hygiene is very good at preventing the development of sleep problems, and as opposed to trying to treat them when you've already developed so many bad habits and this is an ongoing condition thing. It can certainly help it can help prevent it from getting worse. But in terms of treating it, that's not surprising that it wouldn't treat chronic insomnia.
Well, Dr. Arand, thank you so much for joining us for the live Q&A session. It's been a pleasure to have you this afternoon. For those participants, for credit to attend this session, please fill out your form and submit it online, and we will be back in touch. If you wouldn't mind clicking the link to the next track in this sleep track, we will follow up in just a couple moments. Thank you.